Hello, good afternoon, good morning. For those of you further west than us, we're just going to give it a second for all the attendees to come rolling in. Okay, well, let's say we can go ahead and get started. For if this is your first time, Magnolia, we meet every month. Goal is to talk to you as experts in industry and bring other experts in industry to talk about interesting topics and things going on in our world related to market access, related to health economics, real world evidence, and health policy. So we are excited today. We decided it would be a good time to do a mid-year policy update. So that is our topic today. We've got some fun things, just a few things happening in the Washington, D.C. area. So we're gonna dive in to those topics. Just so you know, if you're participating and you'd like to ask any questions, there is a Q&A section that you can put in questions, or there's also a chat. So feel free to do either or. I kind of monitor them as we go. Feel free to populate questions in as we're going if anything comes up or you want to learn more. So great. Okay, well, just in way of introductions, so I'm Amanda Voorhees. I am fortunate enough to be the managing partner here at Magnolia Market Access. My background is in policy, pricing, and reimbursement. I look at everything from a very quantitative lens. So as I'm reading all these things and talking through these things today, I help our clients figure out like what's the impact to your company, to the federal government. I do a lot of more of that like macro and microeconomic evaluation of policy. So happy to talk through some of those things today. And I will turn it over to Tracy Baroni-Almond to introduce herself.
Thanks, Amanda. Good morning, good afternoon. Tracy Baroni-Almond, Vice President of Health Policy and Market Access. I've been with Magnolia 2 years now. And I kind of pick up where Amanda leaves off with the numbers and talk to clients about what you should care about, what your strategy could look like pertaining to certain policies, and what you might want to include in comments, among other things that deal with substantive policy issues. Chris?
Yeah, great to be here. Honored to be a guest on this webinar. And I do all things market access, drug pricing. My clients are pharma companies at all stages of the life cycle, pre-commercial, commercial, brand, generic, the entire waterfront. If you want to keep up on drug pricing developments, check out my drug pricing digest that I push out every 2 weeks. You can find it on the web every second Monday. If you want to get it by email, shoot me a message. I'll sign you up so you can get more spam in your inbox. But glad to be here.
It's actually really great. You know what we'll do when we post these slides, we will put a link to it for Chris's newsletter. It's awesome. I love to read it and bother him about it. So yes, we love having Chris join us. Thank you so much. So today our goal is to, yes, give you a mid-year policy update. We're also going to pontificate a little bit of what we think is going to happen next year after our midterm elections. We've also decided to add a little segment to our Navigating Market Access webinar called the Pets of MMA. Our team, we're a friendly crew. We're a warm, fuzzy bunch, and we all love our animals. And we thought, you don't get to see your vendors very, very often or get to know them. So we thought each month on our webinars we would showcase one of our pets. Conveniently, I chose one of mine today, so we will be doing that and just give a quick little thing. So you definitely want to see a picture of the cutest dog ever, right? And then we will do a quick little wrap up. So thank you all so much for tuning in, and let's dive right in. Okay, so mid-year policy update. I think we've got, a lot of, basically we're in like our rule season, right? So all the traditional rules, we'll talk a little bit about those today. But we've also got all these other things kind of floating around in the world right now. Still, hearing more and talking more about most favored nation agreements that were made, where they're headed, moving toward Globe and Guard, where we have kind of forced basically international pricing policies, and then also looking at how these things are affecting us abroad. So Tracy, do you want to kind of walk us through some of these things going on here?
Sure. I think that we have talked about the MFN agreements and in the past, and I'm sure that most people are aware at this point. But what I think is interesting is how those are evolving. And so Globe and Guard, I would say, are delayed, right? If we're thinking that we're starting Globe October 1st, this is a crunch. So I'm not sure what's going on. I'm not sure if it comes out of OMB. Chris will probably have better ideas. But then there's also the generous model. And recently there was a JAMA article that indicated that there are significant savings for the top 90 high spend drugs that can be gleaned if you only consider Medicaid best price rebates and not take into consideration the state supplemental rebates by using MFN pricing in Medicaid. And so that generous model could really pose some significant savings. And then, just to jump to the ex-US reactions before Chris shares his opinions and knowledge on this, I think that what we're seeing here is the administration putting in place draconian measures to achieve policy change, right? So there's no more soft policy in the United States. And it's working in some cases. The UK, we know, has already agreed to rethink how they spend and what they spend on and what they budget. I don't know that a an investigation into Germany's drug pricing practices is likely to move Germany, or really any country, but Germany especially. And then from a Switzerland perspective, I can't help but think that their change in attitude might have something to do with the fact that there are more than one or two major drug manufacturers located there. And so while those manufacturers would have liked to have pushed Switzerland to different pricing policies in the past, now you've got the whole US plus their presence in Switzerland as, maybe some impetus for that.
Okay. Yeah, I know. Do you guys think Globe and Guard's going to happen? I mean, or soon enough, or you think everything's going to get delayed? What do you think's the plan on that? I'll go to that one first because that's my favorite to talk about because I love trying to figure out how they got to those acronyms. But yeah, how do we see these two playing out? I know it looks like the time's kind of set similar to what we saw with the IRA, where some things under B and D were happening at different points in time, but it just looks like for implementation of this, it's going to be pretty tight.
Chris, I'm going to leave that to you.
Yeah, I mean, like looking at my tea leaves, I don't really know what the thinking is. I mean, they're both at OMB, right? So remember, a final rule has to go to OMB, and OMB has to sign off on it internally, and then the agency has to either implement OMB comments and or just get it out. So these have both been with OMB since June, and if you look at the website for both still says pending review on reg info. So, I agree. It's looking like it's a little tight with the timing. On the other hand, I mean, these, if you think back, what was in the proposed rules, they were pretty baked in many respects, right? And like, what does the government have to do to make this work? Well, they have to go snapshot the international prices, have all that stuff ready. I mean, my guess is they've done that, right? Because if you look at what the proposed rules said about how they can pull the prices from the compendia, what they would collect, they might have done a lot of the legwork. So I'm not so sure that the fact that we haven't seen the final come out yet, that it means they can start pushing it October 1st. So I would just, I think we have to wait and see. And maybe just like a little bit on the bigger picture of this, right? So remember the two prongs, right? One is we're going to force you all to do stuff via tariff threats. And that ran its course with the 17 major companies. All of them got threatening letters a year ago. All of them made deals with limited disclosure about the terms, except that I think it was Dr. Oz who recently said all the agreements end when the Trump presidency ends, which might explain the push by the White House to try to get some of this stuff into the law, right? Because they're kind of trying to make it more permanent. So then we had Globe and Guard, right, proposed rules in December, kind of mopping up the rest of the industry. Well, now everyone's going to be doing some sort of MFN rebate, essentially on roughly a quarter of B and D utilization, and the rebate tied to most favored nation pricing in the basket countries. At the same time, generous, voluntary, right? And the whole way it was positioned, and as we kind of pieced it together from statements that CMS folks were making is like, well, if you come forward voluntarily for generous, maybe we'll give you a waiver on some of the Globe and Guard requirements. So the deadline for signing up the participation agreements in generous was on 7/17. Maybe some folks got a slight extension of that. I don't know. So my expectation would be that a bunch of companies went in and had conversations and negotiations and signed up generous deals. And I think at a politically opportune time, the White House will do another sweet press conference where people can stand and kiss the ring, and will announce more of these deals. Um, so I think stay tuned for that next. So next will be Global final rule coming out at some point. When that comes out, be a lot of work to kind of go and understand what they did and how this is different from the proposed. Um, Stay tuned for generous agreements being announced, and then we'll see if the terms are made public or not. Because if different companies went in and got different deals, are we going to find out what those deals entailed? That'll be interesting to kind of
Mhm.
monitor. And then ex-US, remember the other part of this whole Trump strategy was to say, well, we're paying too little in the US, so we'll push our prices down, but in these other countries, we got to make them jack up the price, which is somewhat ludicrous if you know that these other countries shockingly also have legal systems and laws that govern in many cases.
Go figure.
I know, right? Like, who would have thought? Yeah, so Germany just actually enacted this big reform of the entire health system, blah blah blah. So I am from Germany, but I don't like do the German healthcare stuff. I don't think the German, recently enacted reforms did anything to raise drug prices. I would be shocked if that's what they did, because instead they're doing things like cut mental health services to save money. I have grave doubts that these countries are going to be like, well, we're going to cut back services for our patients here so we can increase drug prices to make the US happy. It seems a little bit unlikely, but I think the important thing with the ex-US side is if you are a US company and you are thinking about launching in Europe, you're thinking about licensing your stuff out to Europe, which of course, as we know, for emerging companies is a big way to, generate some income early in the process. If you can sign licensing deals with Europe while you're working on your US approval, you're getting close to approval, that's usually an important injection of funds into your company. And these are the things to really carefully investigate and evaluate nowadays. What is it going to be doing to my US market? Like Tracy said,
Mhm.
if I'm coming out of one of these basket countries, that might be a tiny country, and my huge US market suddenly gets pegged to pricing in some random place. So a lot of kind of, deep analysis recommended there for sure.
So when I say this, I don't imply that I want to see it worse, right? But when we were expecting Globe and Guard, a lot of people were panicked it was going to be 100% of drugs, but it really was a skinnier version of what was expected. And usually when these things come out, obviously a lot of our clients, they want to work on comments, they want to, it's panic, it's a big thing. I didn't feel like it was as intense as I expected originally. And then I'm looking at companies who made agreements. If you made an agreement that was really aggressive and then you're seeing this Globe and Guard 5 year, certain number of providers, certain number of products, maybe you weren't going to be as affected by Globe and Guard and you actually possibly gave up more on the MFN agreement. How do we think that's going to play? Like, do you think companies are going to say, I'm not making any more negotiations or agreements with you because I'd rather just go with what came out? Or do you think that their deals, quote unquote, were better? Or some, we think they're excluded, right? We've heard some are excluded, but would they have been better off not being excluded?
Yeah, that's really tough to know because it's going to depend on portfolio by portfolio, maybe even drug by drug, right? Like what made sense?
Mhm.
Like some companies, would it have made sense to come forward and have a generous negotiation? If all your revenue comes from Medicaid, probably not, right? You would have been fine to say like, sure, bill me on some Medicare stuff because that's not where my portfolio is or not where my key products are playing, right? So I think that's really kind of a case by case determination by companies. To your point about the scope, yeah, well, first of all, we have to see what the final now does, right? So the final could
Mhm.
be harsher than the proposed. But the other thing to remember is these are CMMI payment models, and there is a pathway to expand them once they start. So the
Mhm.
reason why it's 25% roughly of your Part B and D utilization is because it's supposed to be roughly 25% of the country geographically that gets sucked into this. But it's a little bit similar to clinical trials. If you're doing a clinical trial and your drug is saving lives, it would be nuts to not expand the participation, right? So everybody gets the drug, right? It's the same with these CMMI models. If you kick off your model and you realize there's a huge benefit here and no downside, CMMI can itself kind of say like, well, let's expand it now. Let's go to like 50%. Let's go to 100% of the country, right? So there is even if the regulation doesn't say anything about like, oh, we'll check it and maybe we'll expand it, that's already kind of contemplated in the way that the models are set up. So we might get the final, maybe we're still at 25%, but we might come to next year and shockingly, oh my God, this is saving so much money and the standard of care has not gone down. Let's expand this through the mechanism of, the CMMI models that's already there. And then all of a sudden you do have more coverage, right? So there's kind of that thing to remember. And then just overall conceptually, right? Once they attach the thumb screw on you, it's never coming off, right? And it's never going to get loosened. And once it's there, like once they put it on, you're like, this hurts a little bit, but I can live with it. It's going to get cranked, right? They'll tighten it up because this will obviously save money. It'll be a money maker. And there's always a need for pay-fors to fund random other things, right? So
Mhm.
once this mechanism is up and running, it's going to get harsher and not better.
I guess the only thing we wonder then is how long will it take them to do the analytics around it, right? Because CMMI kind of moves slowly in their program evaluation. Are we going to see a change in administration and a change in priorities and opinion there too? I guess is like another thing, or they're going to want to put their name on something else and call it something else, so, but not have the Trump admin on it. I guess is the political end of it too. But you're right; it's like once you're kind of in, more could happen. So yeah, these are big things. So great. Tracy, before I kind of pop us to the next one, is there anything that you wanted to highlight on this
Nope,
slide?
nope. I think we've done it.
Okay, great. All right, PBM reform. This is one that actually another one that, we saw it in early in the year, didn't hear as much of a flurry about it as you would have expected. I mean, I think a lot of people aren't necessarily assuming it's going to play out the way it is, or the way it's written, that all of a sudden fees are going away and money's being saved. But this is definitely an area that I think has been relatively quieter than I expected on the manufacturer side. Tracy, you want to talk a little bit about this one too?
Sure. I agree with you that we're not hearing a lot from manufacturers about this, but I think that doesn't mean that the PBMs aren't scrambling beneath the surface, right? Kicking like crazy to stay above water because these are significant changes, especially whenever you think about it through the lens of it's not just Part D, it's also commercial. The Department of Labor is looking at additional changes to PBMs that service ERISA plans. And that's always kind of been a loophole, right? We can talk about the different provisions that states have put into law from pharmacy networks and non-interference and PBMs not owning retail pharmacies and all of those things. But the majority of lives are in self-funded plans. And when the DOL decides that they want to take a look at PBMs and their business behaviors and their fiduciary responsibilities that may or may not exist or should exist, I think it becomes very serious. And then I think there's another aspect, and it was touched on a little bit by the FTC settlements. Well, first of all, the fact that there were FTC settlements, given kind of what one could call the erosion of the nonpartisan nature of the FTC. The fact that they did push through with settlements for the two PBMs is, I think, significant that this has been viewed as a problem within this administration. But the fact that they include a provision that says that your GPOs can't be offshored, that's always kind of been a concern, right? Because you don't know what's going on in the Zinc GPO because it's not US based. And so
Mhm.
while I wouldn't say any of this means that there aren't 10 other ways the PBMs are thinking of to make money and collect fees that aren't covered by any settlement or any law, I think this is significant movement toward the regulation of PBMs. And until they have their thinking caps on and decide how else they're going to kind of get money out of the system that can't be tracked or prohibited under these regulations, I think they've got to be a little bit concerned.
Absolutely. Yeah, this is
Yeah.
definitely a, oh, God. Sorry, Chris.
Yeah, I mean, just to jump in real briefly, I mean, yeah, so the Trump presidency began, there was not that much talk about pharmaceutical reforms. That was kind of held more quiet. There was a lot more talk about PBM reform, and now we're kind of like almost at the halfway mark, and we've seen seemingly a lot more action on the drug pricing front versus the PBM front. I mean, one thing that's also noted on the slide here is the Trump RX piece, right? Like one downside to that has been if you just go pay cash, maybe it's cheaper on Trump RX than your copay for your insurance. But if you go through insurance and pay the copay, then that whole thing counts against your out-of-pocket and deductible, right? And so one
Mhm.
thing, as it says on the slide here, in one of the settlements was to kind of make the Trump X purchases count against the out-of-pocket slash deductible. So, that's something to track just to see how it goes forward. Trump X has expanded, right? They started with a certain number of drugs, added more brand drugs, added generic drugs. And so, part of tracking that will be to kind of see how that fits in with the PBM changes.
Yeah, absolutely. It's gonna be interesting to see how that tracking is happening just from like an operational perspective and how you're going to map that all back to a patient's move because it's not working within the standard claim system. So it's a pretty big process, I'm sure, with the way that Trump RX isn't set up like a typical pharmacy claim. So I think operationalizing that is a heavy lift. So it sounds great in theory, but seeing how that's actually going to play out will be interesting too. So, great. I'm just see if I've got any questions on this one before I hop on to the next topic. So, yeah, so this is a big one. Keeping our eyes out. Do we expect more PBM reform? What are we thinking? I think, oh, I have that in my what do you think in 2027 slide. But do we expect anything else this year? Kind of beyond some of this, do we expect bigger, larger moves in general, with just the concept of general like rebates, like commercial rebates, point of sale? Do you see that topic coming back up? What are we thinking on the PBM side in the future?
I mean, personally, I think that there there are ways for this to be implemented that are not
Hmm.
maybe exactly in line with what the law requires. Like in
Hmm.
some cases, maybe it just says, and I know some of the state laws say this, you have to offer a pass-through plan. But
Hmm.
when the costs to the employer are so much higher for that rebate pass-through plan than a fixed plan that still allows spread pricing, uh, as an employer, you want low cost, but you also want predictability, right? And if you say, look, our estimate is that it will cost you 20% more to have rebate pass through, they're going to go back to opacity again,
Hmm.
as an
Hmm.
employer, because what you need to know is how much is this plan going to cost you?
Yep.
So I think these are there's so much that you don't see that goes on in the PBM world that I think that we may not see the benefits that are expected out of this, which doesn't, I think, get us more PBM action this year, but I think it gets us more PBM action in the future. In other words, it's going to become like 340B, where it's the gift that keeps on giving for like 2 decades.
Yep. Yep. Absolutely. Okay. Speaking of 340B, we have a lot going on here. So we're going to talk here about the 340B rebate model. There is the giant part of the outpatient prospective payment rule that came out about changing reimbursement to 340B entities. We'll get to that in just a minute. But let's talk about the rebate model. Is this thing happening? And how's it going to work? So Tracy, you want me to chat through this one or you want to cover this guy right here?
I feel like we should just flip this to Chris because you know I I think that this is very feasible, but that doesn't mean that it's going to happen, right? We know that manufacturers can do it. We know they're doing it through the Medicare Transaction Facilitator. They're paying within 14 days for MFP drugs. We haven't heard any huge outrage from the pharmacies and, acting like the dish pharmacies are, small little entities that can't float that cost. CVS pharmacies care just as much about that as any dish. So
Mhm.
I think it's a false flag, but much more interested in Chris's perspective.
Yeah, so
Yeah,
the
and this
issue,
is an area where, yeah, go ahead, Grace.
well, the issue with all this is like, how much time do we have, right? I mean, none of this is rocket science, but just like the volume of stuff going on is just kind of nuts. But maybe let me just set the stage here, right? So we all know the reality, right? You're supposed to give the 340B price up front, and you're not supposed to ask questions. The whole pay and chase insanity, right? Which, let's just remember, does the law say pay and chase? Does the law say that? No, it doesn't, right? This is all the fun guidance going back to the 90s when this program was new, where it says like you cannot condition your offer of the 340B price on compliance. So what's changed is court cases that were prompted by the contract pharmacy initiatives, including a case that my firm won for a client that says, it's a circuit court case that says, it is permissible for manufacturers to put conditions on the 340B offer, reasonable conditions. So the court didn't tell us what those conditions are, but you can put conditions, right? So just sort of like the landscape has changed because we've had these victories in federal court. So here with the rebate model, that interrupted here is the 340B statute in the very first paragraph says something like, this is how the price works, blah, blah, blah. And then it says, or via a rebate at the discretion of the secretary. And we all know that ADAPs have been getting the 340B price through a rebate for years and years and years, right? So what's the benefit of effectuating 340B price through a rebate? Well, you would sell at whatever price, and then the cover entity submits something that says this is a 340B eligible dispense, and then you wire them the money to lower them down to 340B price. Makes logical sense to me because it fixes all these problems, right? This whole like, oh, we dispense to random people, we figure out later if they're eligible, then we replenish. I mean, the opportunity for mistakes, rampant, right? Shocking little errors where there's way too much being purchased at 340B. So if you were to switch to a rebate, that would kind of be ameliorated because you would then get some evidence for yes, this is 340B, right? So it kind of fixes a bunch of issues. So the
Mhm.
fight initially broke out where some manufacturers were saying, I can do this on my own, right? Just like manufacturers said we can do contract pharmacy limitations on our own, and they won on that one. On the question of can a manufacturer on its own implement rebate effectuation of 340B price, the answer was no. And so the manufacturers lost at the district court, and just this week, the circuit court affirmed that holding, right? So the circuit court, DC Circuit, has said manufacturers on their own cannot implement the rebate model. So that's sort of like one track of this. The other track is the government jumping in and saying, well, let's do a rebate model to kind of test this out, right? And they published that last year, was supposed to start January of this year. It was very limited just to the drugs with an MFP in effect, right? So that's not a big universe of drugs. Nevertheless, the hospitals freaked out and filed litigation against it. And through conversations and settlement, the government pulled it back and killed it, right? So we have not had the rebate model in effect this year, although it was ready to go January 1st. It got killed at the end of December. So then the government said, well, let's do this again, and we'll try to address some of the concerns. And they went forward with creating a new notice on a rebate model which in May was sent to OMB for review and remains under review. So we don't know yet what will really be in that new rebate model that's going to come out here at some point anytime. The latest thing was in June, HRSA issued this ICR notice. So whenever the government collects information, they have to go through this thing called the Paperwork Reduction Act, which is hilarious because the one thing this law did not do is reduce the
Just
paperwork.
there.
Yeah. And so, but it's like it's another window into the process, right? So HRSA published these forms and details around what they expect, how hard this will be. So that was kind of like the latest news that came out. So do I think the rebate model is going to go forward? I think absolutely, because last week the 340B Coalition Summer Conference concluded here in DC. And so the 340B Coalition is the, partisan cover entity organization. They do two annual conferences, one in the spring on the West Coast, and then the bigger one is on the East Coast, and that one just concluded last week. Interestingly enough, there were no HRSA speakers there, but two very high-level CMS speakers were there, which shows a lot of interest by CMS on the 340B space. And the rebate model was kind of discussed, and just reading between the lines, it looks to me like HRSA/CMS is definitely standing behind the rebate model, and we'll get something coming out. When, like with all these things, it's opaque. There's no timeline, there's no deadline, so we don't know. But yeah, stay tuned for some sort of notice coming out that kicks off the rebate model again.
Yeah, I mean, if you had told me 8 or 9 years ago, like we're going to set up something like this, I would have, I guess, thought more deeply about the impact to providers. But then looking at the different contract pharmacy policies, all these people having to give data to all the different, there's Model N and BRG, and everyone's using a different system, and the hospitals are going in and uploading data already, talking about their patient mix for the manufacturers to see. It's like, is this another step that's actually going to be that hard for them? Or are they literally going to just flip a switch with their data vendor and their data vendor is going to do all the work for them? So definitely something to kind of learn more about and see. But yeah, I don't think it's a different difficult concept to think about, especially too with you mentioning Tracy with like the MTF payments happening within 14 days. Like we have figured out how to do this, right? So one analysis, I don't mean to like get people like go to our website, but we did actually look at kind of like financial flow and capital investments within the hospitals, and they do have a lot of cash like year on, right? Throughout the year. It's not like hospitals are sitting in this like massive dip and they have to, figure out their financials week by week. They do generally have a cash flow, surplus during the year. I think it's also important to mention when a hospital does their cost report reconciliation with CMS, like at the end of each year, they have to file their cost report. That reconciliation process can take like 2 to 3 years per cost report. So they're waiting on a check, even from like the government or waiting to pay the government for years and years, right? So we're talking 2 weeks. They're looking at years then for cost report reconciliation. So I think that's just putting things in context. Is this isn't really that bad when you're looking at something at 2 weeks. And I do think and you mentioning, CMS, I never in my life would have thought these words would come out of my mouth, but they're going to. CMS, in my opinion, probably should be looking and managing the 340B program because they are good at regulating. Not that I like their regulation, but they know how to regulate, right? And they're monitoring and they would have a better handle on it with the way that their agency works. I literally do not ever want that quoted. Like if I run for office and all of a sudden I see a quote that's like Amanda said she loves CMS regulation. No, a total false quote. I'm just saying in general, they're better at it, right? They have their processes down. So do we see that shift? Is that a good thing for 340B? And I personally think it could be at this point because we've just gotten to this point where we're so out of hand. But setting up these processes, I feel like is something's got to happen and something's going to give if it doesn't. So
Yeah, I mean, I think like 10 plus years ago, there was a pharma comment letter on something where they suggested, why don't we shift this program to CMS, right? So this idea has been out there. The president's budget for both years made that same suggestion. And so one
mhm.
question is that likely to happen? Is it possible that OPA could kind of shift from HRSA over into CMS in some form? I mean, look, if we just look at what has happened here, right? We have the 3 coalition conference, and we have two high-level CMS speakers there, and they kind of got grilled on the stage, right? But they were there, nobody from HRSA. You kind of go like, well, gee, I wonder what that means, right? So like
Yeah.
I feel optimistic. And like you, let's be clear, right? This administration is not pro-manufacturer. I mean, there's nothing anywhere where that kind of looks like it's pro-manufacturer. But they're also, though, not rabidly pro-covered entity like HRSA has been, right? I mean, HRSA has been completely partisan for the last 30 years to the point where it's ridiculous some of the things they've done, right? So
Mhm.
yeah, I think if this does shift to CMS, we will see more professionalism. It's a better funded agency with more people, right? So we're not going to have this issue anymore of like, well, we got 5 people at OPA running $100 billion program, right? So there's definitely upside to be expected. And just from the legal side, I had mentioned before, right? Some of this weird HRSA guidance is going back to the 90s. It's guidance. And so they initially they published it in the Federal Register, but they called it a notice, right? So it's like stuff on the website. So if you have a new sheriff in town coming in, taking down a regulation requires kind of like a new regulation, right? Or like a rulemaking process. Taking down crap on the website, it's not that hard, right? So I think there is the possibility if there is a shift in who runs the show, yeah, we're not going to see pro-manufacturer and pharma-friendly policies, but we might see some cleanup of these kind of like outrageous aberrations that were just driven by, I think, frankly, a misunderstanding of the nature of the program.
Very good points. So 340B gets me really fired up, as we'll talk about in a few minutes too. So just some other quick things we're going to highlight on as well around Medicaid work requirements, seeing some changes in there. ASP reporting. I know Chris gets all excited talking about that one. And then the state Medicaid fraud withdrawals. So why don't we talk through these, Tracy?
Sure. So I'm happy to take the two Medicaid, the bookends. I think we all recognize that when you talk about work requirements, there are definite questions as to whether it can really be implemented, what the paperwork looks like. This could be a lot like the Medicaid unwinding, where people are just excluded because they haven't filed the paperwork. They don't have the right diagnosis. They have children under the age of, I think it's 10 is required, but they haven't filed. And I've also seen reports out of like MedWatch and Kaiser Family Foundation indicating that physicians are not looking forward to 2028 whenever they have to be the people who indicate that a patient is medically frail and so should be exempted from the work requirements. And once they're exempted from the work requirements or not exempted, what happens to them, right? And so I think you have a situation where you're going to have even more people falling through the cracks. State Medicaid fraud and funding. This is so interesting because in the past, what we've seen is there are fraud investigations, there are convictions, but generally what we see is that about 77% of what's been identified as questionable turns out to be insufficient documentation. And so if you think about, in this case, the $1 billion that's shared between California and Minnesota, they've identified these as questionable claims that need to be looked into further. It could be that 77% of them are actually legitimate. They just have insufficient documentation, and yet they're withholding the money proactively. Um, I don't know of a state that can go without that federal match for very long, especially given that education funding is being taken and road funding is being taken and anything that refers to DEI, those grants are being taken, whether it's, state research or state agencies. So this is significant. And I don't know if they've filed suit yet, the states of California and Minnesota, but I would expect that they will, because to ignore the fact that most identified fraud can then be identified not necessarily as fraud because it's just been not properly documented, but to withhold the money proactively before even conducting that just seems to me to be needlessly pressuring the state systems. And let's face it, these are state tax dollars, and people who live in those states are paying for this money to go back to their states, and this has now interfered with that. So
Yeah,
Chris, talk
I
about
mean,
ASP or Medicaid,
yeah,
whatever.
yeah. Well, I'll limit myself on this Medicaid thing. It's just an odd coincidence that the biggest fraud is happening in the Democratic states, right? That's just like a weird
Shocking.
coincidence. It's like,
Mhm.
yeah, who would have thought, right? Like nobody would have expected that that's how it plays out, right? So I'll stop
With
there.
presidential contenders, right? You have a previous VP candidate and clearly Newsom's running. So
Yeah, it's just all
so
coincidence.
surprising.
Yeah, it's just all like random. So I'll stop there. Yeah, ASP reporting. So look, next week is the deadline for Q2 ASP submissions. And CMS tried to implement this for Q1. They had a kerfuffle with the Paperwork Reduction Act timing, so they couldn't do it Q1. So they're doing it now. So with the Q2 submission, manufacturers have to, for the first time, report a bunch of new stuff, and most importantly, had to obtain and submit certifications from the recipients of service fees that those recipients are not passing the fee along to anyone in order to then be able for the manufacturer to exclude the fee as bona fide service fee from the ASP reporting. So what we're going to see here probably is when the ASP figures are published, or the payment limits, the ASP figures are not published, but the payment limits are published for this Q2, we might see changes because there might hypothetically be manufacturers who were treating service fees as bona fide on the presumption that they were not being passed through, were then not able to receive the certification from the counterparty, and so therefore now have to possibly count more fees as discounts than they had to before, and possibly that might lead to a change in the payment limits. So I think, the question here is like, why, right? Why this and why now? After decades of no regulation on this topic anywhere. I mean, the last time was 2016, a safe final rule on the Medicaid side that CMS spoke of a bona fide service fee. Why suddenly is it coming up now? So if you think back to certain statements that CMS folks made at conferences, or one was a guest on my podcast that talked about this, the concept of gaming came up multiple times. That we hate gaming, we're going to go after gaming. And so you have to wonder why suddenly focus on bona fide service fees and impose obligations that, rightly or wrongly, might result in reduced payment limits, so like reduced outlay by Medicare Part B when it reimburses for drugs. So I think this is really kind of like laying the groundwork for potential enforcement. So if you had a payment limit for your code and it suddenly goes down significantly after this change, You might want to be ready for some questions to come your way about, well, all these years you were reporting a certain ASP and the payment limit was a certain level. Now, because of this change, suddenly your ASP has gone down and so has your payment limit. We want to talk to you, right? So, as ever, have a mailbox that is monitored all the time, that you have as the contact address on all these reporting systems, whether it's MDRP, whether it's the ASP reporting system. Have a good email up and running and check that email every day. So if you do get some outreach, the most important thing is to respond ASAP and have a plan. So yeah, I would carefully track developments there if you're a manufacturer.
Did you see these being like 5 to 10% reductions given some of the fees? Because I'm wondering now if you're going to start seeing your buyers reaching out and you're almost going to chase your own ASP down because they're going to have this cut and then they're going to want a deeper discount before you know it. You've really affected your ASP over the next year versus it's just being like a one-time hit.
Yeah, this could be some dislocation, so I can't really tell you what the figures might
Hmm.
look like, but I would say definitely track it. And the other thing to track is what's happening on the Medicaid side, right? So we have this weird divergence now, whereas on the Medicaid side, we're operating under the 2016 regulation and the associated guidance, where CMS says you're entitled to presume that there is no pass-through unless you have evidence to the contrary. And now we have on the ASP side, on the Medicare side, no more presumption, get the certification, right? So we have like a split in the legal standards that apply to both these programs. Why does it matter? Well, it's because there's AMP ASP substitution, right? There's a metric if the ASP-based reimbursement as compared to this hypothetical AMP-based reimbursement is higher for more than a certain level for a certain time period, CMS can calculate the payment limit off of your AMP. And so then all of a sudden you're in this world of kind of like how do these things relate, right?
Hmm.
And so it's just yeah. So track what happens with your own ASP figures, be on the lookout for what's happening with payment limits generally, and then track what's happening on Medicaid to see if there's going to be any impact.
Yeah, so get on your ASP ASAP. This is why I'm your moderator today, guys. Forgetting you my mom jokes. I guess they're worse than dad jokes. Great, thank you. Okay, so oh wait, did I? Okay, I went to the right slide. Sorry, I thought I hit too many while I was laughing at my own cheesy joke. Okay, so let's talk a little bit about the IRA and looking at changes in patient cost sharing. I think this is some interesting work we've been doing. And yeah, go ahead, Tracy. You want to take us away?
Sure. I think that, this slide really just explains to us where the Part D plan is going. We know that the PDPs, the freestanding PDPs, are under a lot of pressure. When we look at deductibles, the number of patients that have deductibles for the MAPDs has gone up significantly, and yet generally PDP patients also have deductibles, and they're increasing. $53 for the PDPs and 143 for the MAPDs. Similarly, cost sharing is shifting. This can't be explained except to push it back on the changes to the IRA. And I don't think it's about smoothing, right? I think it's about the maximum out of pocket. I think it's about the changes to catastrophic. And the PDPs are in distress, and the MAPDs are taking advantage of the ability to make some changes that they can justify because the benefit design has changed. And so when we think further about, co-insurance versus co-pay, but then also what do premiums look like in the future? And we don't necessarily talk about this in any of the slides, but the premium subsidy model that was put in place that is, it's been made very clear by CMS under this administration that that's intended to go away, that you need to be able to adjust to your new reality. And then, other research we've been doing outside of this that shows that there are a lot of national plans that are pulling out of the Part D marketplace. So MAPD could soon be, the predominant choice by a lot just because there are no other choices, or the choices are, regional and state level plans. So it's, I don't want to say it's a crisis, but it's not trending in a good direction.
Yeah. Yeah, this is definitely, and a lot of these policies, when you're looking at what were, premiums going up, patients being affected, their costs not necessarily changing. And then you see all these things about drug prices dropping and like what's actually, or reimbursement for things, but what's actually going to be passed through to the patient versus a savings to the government. I think that's important too. Like, are these policies in fact going to save patients money? And I think a lot of the things that we're looking at here don't necessarily just turn around to the patient really seeing a tangible difference because maybe even if their out-of-pocket changes, their premiums are going to go up or costs are going to go up elsewhere. So it's a lot of balloon squeezing for patients. So, Chris, did you have any comments on this one before I hop to the next one?
No, I think I've already talked too much, so I'm good on this one.
No, you never talk too much. No, absolutely not. Okay, these are two pretty big things that I think are important to talk about on the IRA side. So, looking at the combination drugs in the recent policy that CMS has proposed around there and Part B effectuation. So, Tracy?
I think that was Chris trying to tell me that he doesn't want to speak to this slide, but I really think he's probably better positioned. I will say that under the combo drugs, QSSD has been a bit of a disaster since the law and the initial guidances. I think that CMS has done everything it can to really push the envelope. And so this is really just the most recent pushing of the envelope. And I know that manufacturers who, I mean, I think, hyaluronidase to make a sub-Q formulation is a big target here. And so I think manufacturers are very willing to stand up for the funding that they've put into this research to develop a new product that's more convenient for patients. So I would expect there's going to be significant pushback on during the comment period.
Yeah, and I think this goes back to this gaming comment I made, right? I think CMS may have thought of this combo drug situation as, oh, this is an opportunity for people to randomly add active ingredients to their existing products and then claim it's a new QSSD. To which my response is, do you understand what it takes to go to FDA and add a new active ingredient to your product? No one's going to do that on a whim, right? I mean, that is like a whole gigantic process. So I think CMS could have rested easy and not have been concerned that, oh, people are going to randomly add active ingredients and create new QSSDs left and right, because that's just not the reality, right? So, but unlike with many of the other things we've discussed, here we have open comment periods. So the time to be heard is now, right? So this combo drugs thing, this came in the proposed regulation to implement the negotiation program. So far, it's only been guidance because the IRA, in its wisdom, allowed CMS to implement the negotiation program, shifting around billions of dollars through guidance or program instruction. This is the first time for 2029 that they have to now do notice and comment rulemaking. So they did kind of collect comments on the guidance so far, but it was kind of like, oh, we're doing this voluntarily. We might ignore stuff. This is now notice and comment rulemaking. They have to look at your comment. So if you have a concern with any of the stuff that's in there, I mean, this combo drug was just kind of like the top issue. There are other issues. Now is the time to get your comments in by August 17th. Remember, if you want to litigate on something and you did not comment on that issue, in many federal courts, you are going to be precluded from filing lawsuits, right? Because the theory is if you didn't complain to the government, you didn't like it, don't come back later and sue them when you didn't use your opportunity to put your comments, right? So the commenting is not just, focused on I want to get my comment in because I hope they're going to change stuff. If you have a likelihood that you need to litigate this later, you better be on file with some comments. Same with this Part B effectuation, right? So 2028 is the first time that Part B drugs are subject to the MFP. And this guidance document, we're back to guidance on this one, talks about how will that MFP be implemented for Part B drugs. Same thing. This one is more of one of these voluntary comment periods, so less significant than the one on the left box. But hey, comment period is open, right? And so if we don't like policies that are being put on us in our industry, we can grouse about all we want, but the opportunity to have our voices heard is with these comments. Comments are a bit of a hassle because you got to actually draft something and you probably want to hire a lawyer to do it. It's going to cost some money. At the end of the day, investing, a couple of grand to get a decent comment letter in there, I think that it's a worthwhile investment because it preserves future opportunities. And again, if you're not going to make your voice heard here through the comment process, then like you've kind of given up. So like call to action is these common opportunities are not super frequent. If one is open like right
Mhm.
now, jump on it, put in a comment.
I just had a question come in from somebody, Tracy, when you made the comment about the HA products in terms of the aggregation, they were wondering if there were any perspectives on products beyond just HA that you could think of that might be tangible to think about with these types of things, or is that just a good one to use? And
I mean, I mean, it's going to apply to any active ingredient where you then have, and it adds an additional administration route. So anything else that would be added to hyaluronate or added instead of hyaluronidase that makes a new administration route, I think is intended to be included. I think that generally it's a qualified single source drug grab. Anything that they can pull in under the negotiation. I mean, just by the way they're doing day supply and per milligram and every strength and sustained release and liquid, and they want to do everything under one negotiation, which is, one of the reasons why at the very beginning of the IRA discussion, right after it was passed, every company had to start thinking about how fast can you get different strengths, different indications to market, because once you hit negotiation, they're going to want every one of them, every unit. And what we're seeing also is that the states are the ones that have prescription drug affordability boards are saying, and we're going to just use MFP. Well, all of a sudden, PDABs look much more reasonable and much more implementable because it's the same price you're going to have to be making pharmacies whole for Medicare. Why can't you just do it in Colorado if they assign the MFP and it's the same number and it can be the same process? So this is all growing very quickly, and I think the QSSD and how you interpret this is just one more way that they're growing their influence.
yeah. I know we're running up on time. I think we can tap on these next couple ones really quickly. The Senate Finance Committee did put out an RFI to try to understand some mechanisms that could be used for basically their three targets are lowering drug prices, enhancing prescription drug affordability, and also strengthening innovation in biotechnology. So that is also open. Comments are due August 17th. I know we've been helping a lot of clients do analysis around some of their plans here, but again, this is just a good chance to get some public comments out. Or not we think things will go with this, you don't know, right? We've got midterm elections, we've got a lot of different things, as Chris mentioned. There's so much going on right now. But again, take that chance to get some comments in. They did suggest some particular policies like throughout, as we've kind of listed here on this slide, as you'll see going into some of their ideas, highlighting things around like biosimilars, generic reimbursement. So you're seeing things of like lower cost medications, but also finding ways to for brands or reference products control costs, but make sure that we're still being innovative. So I mean, you're balancing a lot of different things here, but definitely a chance. I don't know if you two want to make any quick comments about this RFI before I hop on to the next one.
Yep.
Okay, great. We made this lovely graphic though that just we did a report on behalf of Bio that recently came out that talked about the process here and how funding, looking at different policies and what's going on at the FDA and all of those things together could really affect ultimately innovation, and just kind of thinking a little bit deeper around how everyone models the impact of, oh, there's if this law happens, this is what's going to happen to industry. With the IRA, this is what's going to happen in industry. Okay, how about like all those things coming together? What's going to happen to industry? So we tried to create like a macro model, almost like a meta analysis, a meta model of all the different things going on to try to do some estimates of what type of impact that could have on future innovation. That's on our website. We can also provide a link to that here, or you'll see it when you have the slides on our website. And then finally, just for this year, we've got the proposed rulemaking. There are under IPPS, physician fee schedule, certain payment changes, some ideas around like site neutrality, looking at changing the way that practice expense is calculated in the physician fee schedule. I think of these three, the main one that's probably got the people most in a tizzy here is CMS coming back to the 340B hospitals being paid back at a lower rate for drugs under OPPS. So before we saw ASP plus 6, is our normal. And then 2019 and 2020, it was ASP minus 22 and a half. That got turned over in the Supreme Court saying that CMS didn't follow the proper rule making procedures to make that happen. And boy, did they sure go ahead and dot all those I's and cross all those T's this time by doing all the surveys that they needed to do. And they've come back looking at all drugs at 340B facilities, ASP minus 33.4%. In addition, there also, of course, is always sequestration added to that. This is a little bit different than the first one. The first one, for example, was biosimilars were still ASP plus 6. Here, there is no separate carve out for biosimilars. There are some carve outs for some specific facilities, but overall, it's a more aggressive cut. This is big. This is huge to 340B facilities. And if you think about it, if they're giving everyone else ASP plus 6 and they're looking at ASP minus 33.4, they're still expecting hospitals to make some money here on the drug, right? ASP plus 6, you are giving them literally a 6% add-on generally to their sales price. Here you're saying, even though we're taking 33.4%, we're still expecting you to be making money, just you're not going to make as much money on us. Again, goes into the whole interesting factor, though, of how they're suddenly pulling back and not having to pay as much. Everyone else, though, is funding the 340B program. So I think that's just a really interesting thing to keep looking at, how they're recognizing how everyone's making money on 340B, but not allowing pharma to in the world. So questions or comments on this one? I'm going to see if anyone's
I
put any
mean,
comments
so
in. But
so just
Tracy,
really
Chris?
quickly, I think it's worth mentioning that the impacted covered entities are going to be DISH, the rural referral centers, the DISH child sites. So we know that this has been an explosion of utilization, an explosion of 340B into higher income areas where there's probably significantly fewer uninsured and underinsured patients, and then other participating hospital outpatient departments. So there's still a lot of covered entity types, the grantees, the PPS exempt cancer hospitals, the children's hospitals, they will not be subject to this. And so I think, what you can truly expect is that the dish, by being impacted by this, will change their prescribing patterns. And so all of a sudden, that 90% utilization of brands may change significantly, right? Which gives a lot of relief to the brand manufacturers and maybe puts the generic manufacturers in a potentially better place because they're effectively shut out of these outpatient facilities because the margin is so good on brand 340B prescriptions. And I also think it's interesting because do commercial plans start to do the same thing? Use that modifier for the federal employee health program whenever those patients are seen in these facilities.
Yeah, real quick on the modifiers, right? So like under the OPPS, the hospitals have to now tag all the claims. It's either I got it under 340B and I'm eligible for this cut, I got it under 340B, I'm not eligible, or I got it non-340B. So claims modifiers on everything. Physician fee schedule. Last year put in place a voluntary Part D repository of data where you would have claims indication on is it 340B claim or not. That is now proposed to become mandatory. So all of a sudden, we have a bunch of claims modifiers being put in place that will help with the deduplication of IRA inflation rebates. They might help in other ways. So a lot of action here on 340B.
Thank you. Okay. All right. I think we've talked a lot about what we expect to happen in the next few months that will lead into next year, but I was just really excited about my little infographic. So we're just going to pop this up really fast, talking about, we're still outlook, right? We're still trying to figure out things with the elections. I'm not at my office right now, but I usually have an 8 ball that I pull up whenever I'm trying to guess what's going to go on in the world. But, I think we're planning on seeing some significant things next year, and definitely going to depend a little bit on elections, but also just on who's at what office over the next few years, right? And policies they're shaping. So, all right, we're wrapping up. Just our quick segment. Of course, I had to leave a minute for this. This is the pets of MMA. And today I would like to introduce you to Barkley. Barkley is my 10-year-old dog. We call her Sparkly Barkley and Puddin' Pop because she just melts to be pet. She's 10. If you stop petting her, she likes to punch you or paw you because she loves pets. She has a nub. My husband makes up all of our dog voices. Barkley has a very prominent Southern accent. Her favorite topic is the Inflation Reduction Act. She was probably really excited to talk on the last one about it. Barkley currently is being treated for cancer. So everyone here on our call that is in oncology, thank you, because my dog has been tolerating it very well, and we've had an extra year with her that we were not expecting. She's very lazy. She doesn't like to move. And everyone always talks about what a round figure she has. Apparently, her tumor, they can't get to it because she's a big girl and she's just very tired of everyone talking about her 90-pound post baby body. We adopted her after she had puppies. But this is Barkley, one of my three horse-sized dogs that you may see in the background when you're on a call with me. But she's definitely a sweetie. So that is Barkley. And we next month are going to take our August recess. So we're going to take a break. We are going to come back in September with our next session. That's going to be all on value evidence, relationships with payers. We have a great team here that's going to get on the phone and kind of talk about what's headed up next there and how to work with payers and all the new ways to present evidence to them. So we're pretty excited about that. Our slides from today will be on our website and the recording. Usually we load it up in about a day. And thank you all for attending. We appreciate it. Thank you, Chris, for joining us. And we'll also put a link to emailing Chris if you want to get listed to his drug pricing digest. It's wonderful. So y'all have a great day. Bye-bye.
Bye.